And so I did change for MRD clinical application more questions than answers. So I will try to sum up what are currently the question we have in using MRD in routine practice, but mainly in trials. So we know that in myeloma, and like Dr. Balaji showed, the response rate is increasing with all the combination, with all the new drugs. And I saw that in India, in the last trial, they have 90% of CR. However, we have to say that even in patients who are able to achieve CR, we are seeing quite a high number of relapse, meaning that even when we are not able to see any more plasma cells using standard methods, there were remaining plasma cells we are not able to see, which will be responsible for plus or minus long-term relapse. And so if we accept that at diagnosis we have 10, 12 tumor cells in the patient, CR can be achieved with only 2 logs of reduction of this burden. This means that some patients could be declared in CR with 10 billions of remaining plasma cells in the body. So what we really have to do now is to try to measure if the patient is just here or if the patient is here, because I don't think that if the patient is here, he has a chance to be cured without any more treatment. In contrast, if the patient is here, maybe he is already cured. So Jill Kaur did show you yesterday the different technologies. So far, we are stuck at 10 to minus 6, meaning that in a patient who is at 10 to minus 6, this means that he still have or she still have 1 million of plasma cells in the body. So of course, if we could have technology to go to 10 to minus 7, minus 8, it would be much better. But so far, we don't have the technologies to go below 10 to minus 6. So she showed you yesterday that the sensitivity level is very important, and we do believe, and independently of the technique, if you are using NGS or flow cytometry, I think that 10 to minus 6 is the most important. And you can see here that in the IFM 209 trial, patient achieving 10 to minus 6. Of course, we don't have a plateau like Dr. Balodi showed, but it's only 4 years. Maybe we'll see in the future. But at least with patients who are able to achieve 10 to minus 6 negativity, the PFS at 4 years is 75%. Of course, we'll have to continue to follow this patient, but I think the objective should be to achieve this sensitivity. So what to do with that? So first, just look at young transplant-eligible patients. In Europe, the top age is more 70 than 75, like in Little Rock or Mount Sinai. So MRD can be or should be measured at different times. We can measure MRD at the time of end of induction, and we will have to define what is induction. After bone marrow transplant conditioned by MEL200, after consolidation, and during maintenance. So first, is it useful to look at MRD after induction? Is it realistic? I think the answer is yes. The Spanish group did report at last ASH that with the trial with 6 VRD, the MRD negative rate after 6 cycles is already 35%. So in the future, and especially in IFM, we will try to have a quadruplet induction, 6 cycle, with a proteasome inhibitor, an IMiD, DEX, plus an anti-CD38 antibody. And we believe that with this kind of intensive and long induction, we will be able to achieve MRD negativity probably in the range of 50%. So this means that in these patients, the question could be, do we still need to perform high-dose melphalan in these patients? And so we could randomize again transplant with endpoints that should be PFS, but also to measure the MRD negativity at the end of treatment. And why I say that is that in the IFM 209 trial, you can see here these 2 curves are for patients who did achieve MRD negativity independently of being transplanted or not. So this means that in some patients, and it would be good to be able to identify this patient at the time of diagnosis, but in these patients, maybe they don't need to have auto transplant. I say maybe because, again, as I said before, our sensitivity is 10 to the -6. Maybe in patients who did not receive transplant, they are just below 10 to the -6, and maybe for patients who did receive transplant, we are at 10 to the -8 or 9. We don't know. So what we have to do is to continue to follow these patients to see if we observe indifference with a longer follow-up. But definitely, I believe that this question should be addressed again for the 3rd time by IFM. Then we can also propose to evaluate minimal residual disease after transplant. And so here the question would be to randomize consolidation versus no consolidation, because if we believe that we already achieve a very good response, maybe consolidation is not useful. Or in contrast, we can say, okay, this patient did achieve already a good result, but maybe with consolidation and maintenance, we will be able to again drop down the MRD, maybe to 10 to the -10, and maybe to cure the patient. And so for this kind of trials, I think that the endpoint should be PFS, but also MRD at the end of treatment and on subsequent years. Finally, we can also look at MRD after consolidation. And then the question will be, do we need maintenance or no maintenance for this patient? And the same endpoint, PFS and MRD at the end of treatment. So as you see, just for patients who are transplant eligible, I would not say we have place for trial. We need trial to address all these questions. Because nowadays, when we are performing MRD in routine for patients, I don't know what to do with the result, really. So if we now go to patients who are positive after transplant, because if patients are already still positive after induction, of course we will go to the bone marrow transplant with high-dose melphalan. So I think the main question is whether the patient is still positive after transplant or after consolidation. And so if the patient is positive after transplant, I think the question should be, do we keep the standard consolidation regimen which was planned at the beginning, or can we say that we didn't get good results with the combo we use at induction, and maybe we have to switch the class of drugs to try to test novel combo in consolidation with the same endpoint than before. After consolidation, if patients are still positive, I don't think they are in a good shape, because we did show that in the IFM 209, patients who are MRD positive at the end of treatment, only 10% of them did not relapse after 4 years of follow-up. In contrast, patients who were MRD negative, only 20% of them, 25% of them will relapse. So I think obtaining MRD negativity is really important. So at this time, of course, we can propose to have different maintenance regimen to randomize a standard one versus a more intensified, for example, LEN versus LEN-IXA or LEN-DARA. Another question that will be proposed by IFM in the next trial is that for these patients to propose a second high-dose melphalan and then go to maintenance to try to rescue this patient and to achieve MRD negativity in these patients. And again, we can use the same endpoint. The third point is, can we use MRD to define molecular relapse? You know that in CML, people are looking at that. So they stop imatinib, they follow the patient, and when the patient becomes MRD positive again, they start again with very good results. So could we ask or address this issue in myeloma? I think it is more challenging because for me, we should have a trial with a randomization of a treatment at the time of molecular relapse versus to wait to biochemical or clinical relapse. And for this kind of trial, of course, the endpoint cannot be anymore PFS. It has to be overall survival. We can also look at MRD, but definitely it should be overall survival. And so the answer will come probably in 10 years from now. Finally, to conclude with non-transplant eligible patients. So now many trials are proposing continuous treatment. And I think that Dr. Facon will defend this position against Dr. Arusso soon. But if we admit that we are using, for example, Lendex until progression, should we do that for all the patients? Or could we have a question to try to stop the treatment at what time? And so the question could be to have a standard arm with treatment till progression versus a treatment that could be stopped at 3 years for patients who achieve MRD negativity at 2 years. I think we need to have one more year of treatment before to stop. And again, for this kind of trial, the objective the endpoint will be overall survival. We can have exactly the same question at the time of first relapse, and Mohammad Moti will conduct a trial in IFM to test this approach, indefinite treatment with Lendex Dawa versus a fixed time. And the objective will be overall survival. So to conclude, definitely MRD for me should not be used in routine practice because I don't know what to do with. Of course, if your patient is MRD negative, it is good to tell him or her, oh, this is good for you, but how will you use this information for the treatment of the patient? I think we don't know. Of course, MRD must be included in all upcoming ongoing trials with a sensitivity of 10 to minus 6 independently of the technology. And as I showed before, I think that we need many trials asking all these questions about MRD to try to know in the future how we will use it. We are hoping that FDA and EMA will accept MRD as a primary endpoint for the next trials. It is not done yet, but even if it is accepted, we need to have all these answers to go to the practice and to help our patients to have the best treatment as possible. I thank you.